For my case study, I have a 58-year-old male patient who is 5'10", which is 178 centimeters, 85 kilograms, which is 187 pounds, and has no known allergies. His code status is he's a full code. He's up to date on all his vaccines. His chief complaint was severe shortness of breath worsening over the past 24 hours. He has an admitting diagnosis of primary acute respiratory distress syndrome secondary to bacterial pneumonia, secondary type 2 diabetes mellitus, hypertension, and hyperlipidemia. His history of present illness is a 58-year-old male with a history of hypertension, type 2 diabetes mellitus, hyperlipidemia, who presented to the emergency department with progressive dyspnea, a fever of 102.1 degrees Fahrenheit, productive cough with purulent sputum, and increased work of breathing for the past 3 days. The patient initially managed his symptoms with over-the-counter decongestants and hydration, but experienced worsening shortness of breath leading to tachypnea, confusion, and an SpO2 of 85% on room air. The patient was emergently placed on a non-rebreather mask at 15 liters per minute and transferred to the ICU for further management. His condition rapidly deteriorated, requiring endotracheal intubation and mechanical ventilation due to worsening hypoxemia. A chest X-ray and CT scan confirmed bilateral infiltrates consistent with ARDS. His past medical history consists of type 2 diabetes mellitus, diagnosed 10 years ago on oral hypoglycemics, hypertension, diagnosed 12 years ago, controlled with medication, hyperlipidemia on statin therapy, obstructive sleep apnea, he uses a CPAP at night, and no prior hospitalizations for respiratory failure. Subjective information was reported by the family as patient was intubated. They had complained of increasing dyspnea and fatigue over the last 3 days for him. Reports productive cough with thick yellow-green sputum. Noted confusion and disorientation before hospital arrival. No known history of COPD or asthma. No recent travel or known sick contacts. His objective information includes vital signs on admission of a temperature of 102.1 degrees Fahrenheit, heart rate of 118 BPM, which is tachycardic, respiratory rate of 36 breaths per minute, which is tachypnic, blood pressure of 88/56 millimeters of mercury, which is hypotensive, requiring pressors. He has an 85% SpO2 on room air, 92% on 15 liters of a non-rebreather. His FiO2 is 100% on mechanical ventilation. We asked about his home medications. He does take metformin 1,000 milligrams BID for type 2 diabetes. He takes lisinopril 10 milligrams q day. For hypertension, he takes atorvastatin 40 milligrams q day. For hyperlipidemia, aspirin 81 milligrams q day for cardiovascular protection, and albuterol PRN, occasional use for mild wheezing. Upon his pulmonary and respiratory assessment, his auscultation findings showed diminished breath sounds bilaterally. He had diffuse crackles through the lung fields and no wheezing or rhonchi. His sputum production was thick yellow-green purulent sputum. His gram stain was gram-positive cocci in clusters. His culture showed Staphylococcus aureus, MSSA. When analyzing his chest X-ray, I did an A through I interpretation. So is A, airway, Trachea was midline. Endotracheal tube was correctly positioned. The bones and soft tissues showed no fractures or soft tissue abnormalities. C. He had a normal heart size. There was no cardiomegaly. His diaphragm. For D, he had blunted costophrenic angles, which is suggestive of mild effusions. E, he had small bilateral pleural effusions. F, diffuse bilateral alveolar infiltrates, predominantly in lower lobes. G, he had gas lines or gas and lines. He had no pneumothorax. He had a central line in the correct position. For H, there was no significant lymphadenopathy. And I, the impression, the findings were consistent with ARDS secondary to pneumonia. For his PFT results, they were not performed due to his acute illness, but inferred instead. So I just went ahead and interpreted what I thought his PFT would be based on the symptoms he was having. So I would expect to see a decreased forced vital capacity, a decreased forced expiratory volume in 1 second, a decreased FEV1 to FVC ratio, markedly reduced diffusion capacity. For his ECG findings, it was interpreted that he had sinus tachycardia of 118 BPM. There were no ST elevations or ischemic changes, no evidence of right heart strain. His echocardiogram showed left ventricular ejection fraction of 55%, which is normal. There were no signs of heart failure or valvular abnormalities. His laboratory findings, we did a CBC. We found white blood cells of 19.5, which shows leukocytosis consistent with infection. Hemoglobin 13.1 was normal. Hematocrit 39.5% normal. Platelets 240 normal. His basic metabolic panel showed sodium of 133, which is mild hyponatremia. His potassium was 4.8, which is normal. Chloride 100 normal. And his bicarb was 32, which is elevated, likely due to the sepsis. His creatinine was 1.8, which is consistent with acute kidney injury. And his glucose was 250 milligrams per DL, which is hyperglycemia. His ABG on mechanical ventilation with an FiO2 of 100% showed a pH of 7.28, which is an acidosis, a PaCO2 of 55, which is hypercapnia, a PaO2 of 62, which is refractory hypoxemia, and a bicarb of 19, which is a metabolic acidosis.